thank you. So apologies if you've heard all of this before, but I'm going to bang on about it again because it's my job. I'll try and put it up in a slightly different way for you. So enhanced recovery came out of Denmark. It was colorectal surgery that originally started in. And they asked the little whys. Why were we fasting patients? Why do we keep them in bed? Why do we put drips and drains and catheters in them? And give them all this stress and take them away from what's normal from them. So they looked at what they were doing and all the individual parts of it and changed quite a lot of it. And that gave them really good outcomes. It reduced the stress response for our patients, and what they saw was a byproduct of that was they recovered quicker and they were able to get home sooner. So a lot of other surgeries recognised that this was a good thing to be doing for patients and decided to pinch the idea. So we've done that as well with our thoracic patients and our orthopaedic patients at the Golden Jubilee, and they've been quite successful programmes, so we thought, why not for cardiac? And that's really what we did. Just to give you a wee bit more detail about the principles of enhanced recovery, I like to think of it as a sort of sports analogy. If your patient is your elite athlete and say that it's an Olympic year, we're coming up for the Olympics, so their surgery is their Olympics, so you want to have the patient or the athlete in the tip-top condition going into that. Really, it's the same sort of ethos for your patients. You want them to be mentally prepared, you want them to be physically prepared. Things like dietary things, getting their pulmonary rehab pre-op, get them all prepared for it, and then give them the best possible experience, and hopefully you win the goal or you get good outcomes from your surgery. And that's really key. The athletes are involved quite heavily, so you want your patients involved in the same way. There's a full team surrounding them. It's the same for the patients, and then hopefully they win the gold. So we wanted to see if we could do that for our cardiac patients, and we chose the elective primary cabbages and tissue AVRs under two willing surgeons to use their patients. We didn't want any patients with cognitive impairment because we wanted them to be actively involved to fully understand what they needed to do, so we had to exclude those patients. And we wanted to test the pathway fully, so we thought we'd make it easier on ourselves and choose younger patients as well. So preoperatively, we looked at how we could change our programme to try and fit the enhanced recovery principles. So we developed some education for the patients. We've got a cardiac information booklet. All the patients get that at consultation. It's quite comprehensive. It takes them through from referral, each stage that they need to get themselves better during the surgery, and then what to do when they get home and who to contact when they get home to get themselves better and if there's any issues. We looked at minimising fasting times. We didn't think that we would carbohydrate load our patients pre-op. There wasn't a lot of evidence to support that, and we'd hoped that they would get back to eating and drinking post-op quite soon. And looked at, instead of blanket pre-meds, looked at patient-specific pre-meds. Instead of giving your wee tiny 40-kilo woman a big whack of pre-med, we tried to make it a bit more specific. Intraoperatively, of course, the surgeons thought that what they were doing was amazing, so they didn't want to really change very much. Same with the anaesthetists, but we have got one surgeon doing minimally invasive valve approach. One thing that we did try to avoid was hypothermia, and consistently try to get patients back nice and warm, ready to be woken up and extubated. Post-operatively, we wanted to try and get our patients extubated a bit sooner so we could start their pulmonary rehab, get them up, if possible, within 6 hours post-op, start them eating and drinking as soon as we can. We looked at our post-op nausea and vomiting and changed our provision for that post-op so that there was more autonomy there for the nurses to actively give out more antiemetics. Our pain pathway is pretty standardised anyway, but what we did do was add in an extra MR dose of oxy for the enhanced recovery patients because we were asking them to do more post-op because we thought they would be sorer, and they actually did turn out to be a bit sorer. And to make sure that we were planning their discharge with them, keeping them that dialogue open with them just in case anything changes, so that transition from hospital to home, because we're sending them home a bit sooner, was seamless. And then I would follow them up sort of 24 to 48 hours with a wee phone call, and then our cardiac rehab nurses would take over 7 to 10 days and call them again to see if there was any issues. So obviously this is preliminary results, very small amount of patients that we've done, only 21 patients at the moment. As I said, we focused on getting the patients ready pre-op, giving them that education, post-op, giving the nurses a bit more autonomy and driving their recovery, and making sure that the patients were engaged to get them to drive it as well. Here's our demographics, really nice boring slide for Tuesday afternoon, which we can just skip past. So we had 21 patients, predominantly cabbages. Our length of stay ranged from 4 to 10 days. We got a bit excited and sent two patients home post-op day 3. And they did well. They were young guys. They did well at home. Median hospital length of stay for both were 6 days, which in comparison to our non-enhanced recovery is quite a few days difference. The mean length of stay for the cabbages, 5.7. The valves stayed a bit longer, but they did tend to be a bit older, had longer ventilation time, had a longer bypass time. That's just to illustrate a nice wee graph. In terms of compliance to enhanced recovery principles that we set out for ourselves, we did manage to get up all our patients before midday post-op day 1. We actually got a couple of them up theatre day. A few of the challenges were we did try to get our enhanced recovery patients first on the list so we could progress them on theatre day, but because of list constraints and consultants want to put more difficult patients first, which is understandable, some of our patients were second on the list, which meant we couldn't do too much for them on theatre day and we had to wait till post-op day 1. Majority of our patients were extubated within 6 hours, and the median actually extubation time was under 4 hours for these patients. And I think in the department as a whole, half of our patients that go through cardiac patients are extubated within 6 hours, so that was quite good going, getting them extubated. And the normal pathway is patients will be stepped down post-op day 1 from ICU to our HDU department. We did hope to send more patients straight to the ward. They should be fit enough to do that. But only 8 patients were able to achieve that. 19 of our patients, we managed to get their IV fluids off, get their diet re-established, and they were managing their fluid balance themselves. But we did unfortunately have 5 delays and 1 readmission. That was predominantly AF, but we did have a patient who developed an ileus and ended up staying 10 days, and a patient who had a pneumothorax after central line insertion, and 1 patient who needed a bit of nasal high flow for a bit longer. The readmission we picked up, because we're a national service, it is a bit difficult for us to pick up readmissions. They don't always come directly back to us. This gentleman, it was actually the cardiac rehab nurses that picked that up. He went home, and then I think it was 7 days after he went home, he was readmitted to his tertiary hospital with AF, which he was treated with and sent home with oral amiodarone. So I think from the tiny amount of patients that we've done, we've had some positive results, but obviously we need to get some bigger numbers. But I think the key thing was engaging with the patients to get them to drive that, but obviously it was a culture change for the staff as well, getting them to mobilise patients on theatre day and thinking about sending patients home quicker. So that is, that's something that we need to then just gain momentum in to make it scalable to the rest of our patients. So far we've seen the cabbage patients do better, but obviously they were younger, they had a shorter bypass time, shorter ventilation times. But we do need greater numbers to see how effective it is going to be in the whole for cardiac patients. We've picked quite a select few patients. If we wanted to scale that up to more difficult surgeries, we'd perhaps need to modify our expectations of how well they would do, but we would hope they would do better. And like introducing things like prehabilitation, which has been discussed quite a bit at this meeting, which is really nice and positive to see that that's gaining momentum. We would hope that that would benefit patients as well as giving them the option to come in, day surgery if they wanted to, try and get them in their own beds and minimise that stress, or they can stay in our hotel if they want, if they're coming from a distance. And this, just a nice wee positive story, this is one of our first enhanced recovery patients who went home post-op day 3. He sent me this last month after he'd ran a 10k to raise some money for the British Heart Foundation. That's me, thank you.